Welcome, everybody. We are here for this year's programming in celebration of Juneteenth, hosted by Kuji Chagulia, Madison Center for Self-Determination. I am Joshua Wright. I will be facilitating this conversation. I am a community project coordinator with the Carbone Cancer Center at the University of Wisconsin-Madison inside the unit called the Cancer Health Disparities Initiative. Today, I have with me Dr. Eva Vivian, and she is currently a professor at the University of Wisconsin School of Pharmacy. She received her Doctor of Pharmacy degree from the University of Illinois College of Pharmacy, a Master's of Science from the University of Wisconsin School of Medicine and Public Health, and a Doctor of Philosophy from the University of Wisconsin School of Human Ecology. She is certified in diabetes education and advanced diabetes management. She currently maintains a practice at the St. Vincent de Paul Charitable Pharmacy. Dr. Vivian's research interest focuses on identifying disparities in treatment of hypertension, diabetes, and other chronic diseases among ethnic minorities, particularly African American and Latino American patients, and developing and implementing strategies to reduce and eliminate them. Recently, her research has sharpened its focus in response to heightened awareness of the great numbers of children and adolescents who are at special risk of diabetes. And as you see on the screen, we are here to talk about the conditions of hypertension, and we want to make sure we focus on how this is impacting the Black community as we are understanding and celebrating another year and celebration of Juneteenth. Welcome, Dr. Eva Vivian.
Thank you for that wonderful introduction. Today, I'm going to talk about the prevalence of hypertension in the African American community and some of the causes of hypertension in our community. Now, all of us have heard the term health equity, but what does health equity actually mean? It means that every person has the same opportunities, resources, and supports that are needed to stay safe and healthy. We know that even here in Wisconsin, and particularly Dane County, that there are clearly health disparities, and everyone does not have the same opportunities or resources that are needed to stay healthy. So during my dissertation work, I often ask myself, why are some people healthier than others? Are some racial ethnic groups just predisposed to being unhealthy or at higher risk for certain diseases than others? And I'll present some answers to those questions. But when we're focusing on hypertension, we learn that the prevalence of high blood pressure in African Americans in our country is among the highest in the entire world, and that the risk of diabetes is 77% higher among African Americans than among non-Hispanic white Americans. In 2006, African American men were twice as likely to start treatment for end-stage kidney disease related to diabetes and hypertension when compared to non-Hispanic white men. So what are some of the reasons for these health disparities? What you'll find is that some of these reasons are actually rather complex. We'll start with the patient-related issues, which are issues that you often hear healthcare providers state. Issues such as the patient has certain preferences, or the patient refuses treatment. They may state that some African American have different types of care-seeking behaviors. There may be some truth to this, but there's an underlying reason why patients may have certain preferences. There's also healthcare system-related issues. For example, the geographic proximity of healthcare institutions to a person's home. We do know that underserved communities have fewer healthcare facilities compared to more affluent communities. Healthcare access and delivery of healthcare services. It's often difficult to get qualified healthcare professionals in some of the local low-income clinics in most major cities in our country. Sometimes there's a lack of interpretation and translation services, and this actually limits the ability of a provider to communicate with the patient. And then, of course, there's the time pressure on physicians. Many physicians are only allowed 10 to 15 minutes per patient, and it often takes that amount of time just to review a patient's chart and learn about the patient. But
Okay.
what is more concerning is provider-related issues, such as biases. I've heard many providers state, oh, African Americans just tend to have high blood pressure and their blood pressure is more difficult to treat. Well, when you have this type of bias, you may not be as aggressive in trying to get that person's blood pressure under control, because in the back of your mind, you're thinking, okay, this person's blood pressure is going to remain elevated anyway. Then
Hmm.
sometimes there's clinical uncertainty about how to treat African American patients' high blood pressure. And there are beliefs and stereotypes about the behavior or health of African American patients. There's a belief that African Americans do not wish to lead a healthy lifestyle without taking into consideration the social and economic factors that could actually be impacting the behavior of many African American patients with hypertension.
Dr. Vivian, this is a great start to this conversation. And I just wanted to hop in and kind of unpack a little bit the point around not having enough time with doctors to talk through some of these issues related to hypertension. And so in my personal experience, I know that I get my blood pressure checked every time that I have an interaction with the medical team and the medical staff. And they'll just mention briefly, hey, it might be a little elevated. And sometimes they suggest to check it at the end of the visit before I leave. And so it just seems like this happens regularly, but there's not much attention given to it. And it seems here that we're supposed to be giving more attention to this issue. And so, do you take the time to, ask a little bit more when you see higher or elevated numbers in these interactions?
Absolutely. There's several issues that I should mention in regard to taking someone's high blood pressure. And I think it's really important that we teach people that when you visit your doctor, you should be sitting for at least 5 minutes before your blood pressure is taken. For example, if you rush to get to the doctor's office and they call you into the office immediately, then your blood pressure will likely be elevated. So you should be sitting comfortable and relaxed for a minimum of 5 minutes before your blood pressure is taken. Also, there is a term called white coat hypertension. And it essentially means that some people's blood pressure just becomes elevated when they're in the doctor's office. They just become nervous being in that medical office or environment, and their blood pressure is higher. And this is why they might recommend that you check your blood pressure again when you're at home. But it's also important that when you make that recommendation that you ensure that the patient has the blood pressure kit or the blood pressure meter and can actually take their blood pressure at home.
Okay, okay, thank you for that. So actually sitting in the waiting room is a good thing before actually getting into the doctor and having that conversation. if you can get there a little bit early and just get a moment to breathe and relax and maybe think of some things that you want to talk about that will be beneficial to having a more accurate reading.
Absolutely. And sometimes the healthcare provider should talk to you about some things first before they actually put the blood pressure cuff on your arm. They can ask you about how your work has been going, ask you about other issues, about physical activity, your nutritional habits, and that takes up about 5 minutes. And then after that, they can then take your blood pressure.
Okay, excellent. Thank you for pausing and going through those things with me.
Oh, absolutely. Please stop me at any time. What we find in African Americans is that there is a striking pattern of accelerated aging, and it has an earlier onset of disease. And chronological age actually captures the duration of exposure to risk for groups living in adverse living conditions. So what this essentially means is that African Americans essentially are aging quicker from within. And we've actually looked at biological markers that have clearly shown that on average, African Americans age about 7 years quicker than white Americans. And we attribute this to the ongoing exposure to stress that we face in our everyday life. So there's Lisa Payton Care of the Foundation of Black Women's Wellness once commented that while we may look younger on the outside, it's really important that we look at how we look on the inside, because this accelerated aging has actually shortened the lifespan of many African Americans.
So I just want to hop in there because that common term or phrase that we hear, Black don't crack, that speaks very pointedly to that saying. And so I'm so glad that you referenced Miss Lisa Payton Care for putting that out there and bringing attention to, hey, yes, we want to continue to look good on the outside, but how we feel on the inside and what's going on the inside will help with the quality of life and our longevity of life.
Absolutely. And to discuss this further, this term is referred to as biological weathering. And Blacks experience greater physiological wear and tear. And overall, we're aging biologically faster than whites. This is usually driven by the cumulative impact of repeated exposures to things such as ongoing racism, physical and chemical stressors within our communities, occupational and social environments, and just coping with these stressors. For example, as African Americans, all of us can say that we've dealt with ongoing racism. It's a part of our society, and it's something that we have had to deal with since our youth. And some of us learn how to ignore certain microaggressions. But while we tolerate those things, they do have an effect on us physiologically. So compared to whites, we experience higher level of stressors, greater clustering of stressors, and probably a greater duration and intensity of stressors compared to, I would say, most racial and ethnic groups in this country. Now, this is a very interesting slide, and I'm going to try to break this down for you. The dark blue bars represent African Americans, and the light blue is white, non-Hispanic whites. But what you can see essentially from this slide, that we as African Americans are more likely than whites to die at early ages from all causes. Here, we have high blood pressure, and we see on the y-axis that there are various ages, from 18 to 34, 35 to 49, 50 to 64. But overall, African Americans, represented by the dark blue bar, are at greater risk of dying of high blood pressure in all age categories. The same applies for diabetes, that in spite of the age category, African Americans have poor outcomes when compared to non-Hispanic whites. Let's look at stroke. Once again, our outcomes are less favorable. So it's really important that we address health disparities because our population is becoming more diverse. And it's projected that people of color will account for more than half of the United States population by 2050. And I actually think that this might be the case today. It depends on how accurate the census is.
Okay, so with those numbers, I do know that I looked up a couple things from the Centers of Disease Control and Prevention website, and it points to high blood pressure being a risk factor for stroke.
Mhm.
And so what we're looking at as well here with that connection is that not only does high blood pressure itself have negative outcomes, high blood pressure also is an indicator that these other conditions put us at higher risk for. And stroke and heart failure looks like it's one of those corollaries, or it's related to that negative outcome. And so I really appreciate that you're visualizing this, and we have lots of work to do throughout our entire lifespans in terms of the importance of needing to address high blood pressure as a condition.
Absolutely. And also diabetes. I
Okay.
tell my patients with diabetes that diabetes and high blood pressure are first cousins. And while I care for people with diabetes, I can tell you that over 50% of people with diabetes have high blood pressure. And I should restate that to say over 50% of African Americans with diabetes also have high blood pressure. And this places them at greater risk for heart attack, stroke, and also kidney disease.
Hmm.
So let's look at the results of healthcare disparities in African Americans. We see that the death rate for African Americans is generally higher than whites for heart diseases, stroke, cancer, asthma, influenza, pneumonia, diabetes, and even HIV/AIDS. So when we look at this, what is driving this? Why are African Americans at higher risk for all of these conditions when compared to non-Hispanic whites? And we look at this particular statement that the life expectancy at birth for Black males is 74 years versus 78 years for white males. Access to healthcare services or health outcomes often depends on who you are, which is really true, your race or ethnicity. Black, Indigenous, people of color continue to receive lower quality care when compared to whites. And this is a quote from the Robert Wood Johnson Foundation. So addressing healthcare disparities is really important because, as I mentioned in the previous slide, over 50% of our population in our country will consist of people of color. But let's look now at some of the factors that could contribute to hypertension in African Americans. Yes, genetics could play a role. There are genes that can predispose us to retain water, sodium retention. There could be genetic mutations, But recent studies have shown that the trauma that individuals face can actually play a role in altering their genes for the next generation. So when you think about African Americans, think of the trauma that our ancestors went through when they were enslaved. And even the generations after them face severe discrimination. Is it possible that that ongoing trauma resulted in alteration in our genes that predisposed us to developing hypertension? We also know that when an individual is very stressed, that cortisol levels and the sympathetic nervous system is overworked. And as a result, that can cause an elevation in blood pressure as well. Obesity, chronic kidney disease, diabetes, these can also increase the risk of hypertension. So the question is it the chicken or the egg? Does hypertension come first? In some cases it does. But does diabetes increase your risk for hypertension? That's a good question. There's psychosocial issues, some of the issues that I mentioned, but also low socioeconomic status. We know that residential segregation has contributed to the poor health of many African Americans. Living in communities where there aren't grocery stores that carry fresh produce, or neighborhoods where it's safe to walk. All of these things can contribute to poor health outcomes, and also poor access to healthcare. And then there's the environment, unhealthy dietary habits, sedentary lifestyle. But we, as I just mentioned, often the environment is not conducive to leading a healthy lifestyle. So we have to teach healthcare providers that it's really important to learn more about the environment that your patient resides in before you make a recommendation to eat more fruits and vegetables and to be more physically active. We have to find out, does that patient have access to fruits and vegetables? Can they afford fresh fruits and vegetables? And do they live in a neighborhood that is safe, where they feel comfortable being physically active?
Yes, Dr. Vivian, just some things pop in my head when you're talking about these things, and the legacy part of what you're talking about, just having things passed down, and how these small things that we're facing on a daily basis end up building up. And for some reason, the movie Green Book kind of popped in my head, but just that legacy of where are you welcome and where are you not welcome,
Mhm.
and how that plays a factor in our daily lives. And you put that together a little bit with microaggressions, right? And how the sensitivity of our blood pressure reacts to these momentary instances, right? And so, just this kind of legacy of the spaces that I have available to me as I'm living my daily life, right? And how does that build up? And so just when I mentioned that movie Green Book, it was just a representation of a real circumstance around places that we are welcome and places that we are not welcome. So going from that state of legal segregation to having to move away from that, and people actually having to still be very hyper aware of spaces that they are welcome in and spaces that they are not welcome in. And so, even in going in coming into these spaces where it's like, okay, I'm going to where the fresh fruits and vegetables are, right? But as I'm in these places, how do I interact with the staff in those places, and are they welcoming to me being present in those spaces? Because I know very much that there are plenty of movements happening around the country where Black folks are taking charge and saying, hey, we want to change our lifestyle habits, and access and have more of these diet friendly things that are going to help me be healthier. And so what does it mean to actually take that on, make that decision. And again, just that small interaction when I'm, picking through the fruits and vegetables, because not everything is always, edible. And so, some of these things are moldy and stuff like that. But as I'm just taking my time, may or may not be something I want, and then just kind of looking over and seeing somebody, maybe like looking at me, and now I'm thinking in my head, is this person, wanting me to hurry up, or they see me touching multiple different fruits, which is normal at the store, but how do I feel as I'm going through that process? And so I really appreciate that you're giving a visualization and talking about these things, because they all add to this equation of whether or not I'm experiencing hypertension in my life. Will I get to that point of being able to have control over my blood pressure, or is it something that is just out of my mind because I'm trying to survive on a day-to-day basis?
Those are all very good points. And last week when I visited the farmer's market, I purchased 2 tomatoes. Those two
Okay.
tomatoes alone cost $5.50. So how can a mother with 3 children afford to purchase lettuce, tomatoes, and other fruits and vegetables and feed her children? It would probably cost about $20 just to prepare a salad for 3 children. So the McDonald's or the Wendy's in her neighborhood is a more desirable option because they have the dollar meals. So these are some of the things that people have to make decisions about every day that are actually impacting their health. And it's not that people necessarily want to live off of McDonald's, but sometimes people are forced to select unhealthy options because they cannot afford the more healthier options. And it's really important that we as Americans recognize our privilege and find ways to help those that have less privilege. So heart failure. Heart failure is a reality. My father was diagnosed with hypertension in his early 50s, and he didn't have a good relationship with the doctors at the VA hospital. So he didn't take his medications as prescribed, and he went on to develop heart failure. But heart failure is driven by hypertension. And Blacks have almost a 2 times higher risk for hypertension and heart failure when compared to white men and white women. So this chart actually shows you the dark blue lines are actually representing Black men and Black women, and the lighter blue lines represent white males and white females. And what you see is that the incidence of hypertension is significantly higher among Blacks. But also what you see is that these 2 charts just merely summarize the percentage of people that go on to develop coronary artery disease as a result of heart failure. And African Americans, you see, are represented by the dark blue lines. And overall, for heart failure, this graph in particular just shows that African Americans were almost 3 times as likely to have hypertension-based heart failure when compared to non-Hispanic whites. So kidney disease is really serious as well. And it can occur as a result of uncontrolled hypertension. So African Americans are twice as likely to be diagnosed with diabetes, but also they have 3 times a higher rate of kidney failure. And if you go to any dialysis unit and you ask the people sitting there, how many of them had high blood pressure at one time, over 50% of them will raise their hand and indicate that they had high blood pressure. So kidney disease is more common among Blacks than non-Hispanic whites. The likelihood of progressing to end-stage kidney disease, which means that you're placed on dialysis, is significantly higher for us as well. So this is a reality, and it's so important that we educate our people about high blood pressure and make sure that they understand how to take care of themselves, how important it is to take their medications. And if they're experiencing side effects with their medications, that they talk to their healthcare provider, because there's so many medications that are now available to manage high blood pressure. And often people can be taken off of one drug and placed on another drug that they can tolerate. So few patients receive optimal medical therapy. So about 1/3 of individuals that are treated with hypertension are receiving medications that are consistent with the treatment guidelines. For example, we do know that African Americans respond differently to different high blood pressure medications. I recall right after I graduated from pharmacy school, I had a debate with one of my professors, and I told him that I felt that the diuretics work better in Black patients than the beta blockers, and that was a different class of blood pressure medication. And he debated me, but the studies that were conducted at that time did not include very many Black people. And what I found from working in clinic with Blacks was that when we gave them a diuretic, that their blood pressure dropped. So it's really important that healthcare providers be comfortable with knowing which medications work best in African Americans.
Wow. Yeah. So just in terms of just understanding those connections is amazing that you're bringing that up as well, because from not being proficient at understanding what the medicine options are, we still should ask those questions when we get into that situation of, do we know if this medication is going to be the most effective for me? Okay. And me as a Black man, being able to ask that question, being prepared to just do a little bit more and understand if that's going to help me get this thing under control. And I'm glad that you're bringing that up, because this treatment of hypertension is part of this outcome that we're talking about. So I really appreciate that you're bringing up that personal experience and having that debate, and just making sure that people understand, hey, what is it saying in terms of the research studies of how people are responding to these things. And then also, I think we're going to get into this a little bit later though, but the importance of being willing to participate in research.
Absolutely.
And-
And I'll share another personal story. Last year, I was diagnosed with high blood pressure, and it was very interesting. The nurse came to me with a medication, which is effective, but I didn't know why she selected that as the first choice drug. Well, she didn't select it, but the physician did. So she approached me and said, "Oh, we're going to start phosphenipril once a day." And I looked at her and said, "Well, why?" And she said, "Well, this is what the doctor recommended." And I told her, I said, "Go back to the doctor and tell him that I recommend that he start me on amlodipine 5 milligrams a day." because this drug has been found to be effective. And I said, just tell him all had study. And it was funny, 5 minutes later, that nurse bounced into the room and she said, oh, here I have amlodipine 5 milligrams. I said, okay. So I took the medication and she waited for about an hour and they took my blood pressure. She didn't even tell me what the blood pressure was. She ran out of the office and I heard her telling the doctor, oh, her blood pressure is like 108/70. I thought, well, yeah. But I mean, I also recognize that everyone doesn't have my background.
Right.
So I think it's really important that we educate healthcare providers too. It's our responsibility to be aware of the current studies that show which drugs work more favorably in certain groups versus others.
Yes, yes. Thank you for sharing that moment of power in terms of knowing what the information says about what is effective and what is not effective or less effective, because we need the most effective opportunities to be participating in our shared health decisions. And so also in that situation, you just kind of raised a point as well. Um, is it okay in these moments to say, hey, I'd like to do my own research before starting this? Or, what happens when they're making that recommendation and how soon it is that it needs to be taken up a treatment plan?
Okay. It depends on how elevated the blood pressure is.
Okay.
If the blood pressure is at dangerous numbers that where a person could potentially have a stroke at any moment. For
Mhm.
example, if the top number, which is the systolic number, is above 200, and the bottom number, which is the diastolic, is above 100, I would argue that the patient should be on some blood pressure medication.
Okay.
But if the blood pressure is just slightly elevated and the doctor wants to start a medication, there is nothing wrong with the patient saying, I would really like to do some research on this medication, or ask the doctor to explain to me why you selected this drug. You may
Okay.
not be familiar with all the drugs, but what you could say to the doctor is, I heard that there's some medications that work better at reducing blood pressure in Blacks versus others. And is this one of those medications? Or why did you give me this medication versus other medications that are available for the treatment of hypertension? Ask your doctor. I mean,
Okay.
yeah, we shouldn't hesitate to ask questions. Don't be intimidated, because healthcare providers are there to help you.
That's what we're paying for.
That's right. And um, they should be happy that you're asking these questions.
Right. Okay. Yes. And just tying it back to something that you had mentioned earlier about the limited time that we have in these interactions. And so it's being encouraged that we take our time and be willing to ask those questions. That's exactly what we're paying for. And we shouldn't be just rushed through based on the scheduling that is on their end. We have our own needs that we have to meet, and I need to be comfortable saying, okay, I have an extra 30 to 45 minutes, so I'm going to take that time. And even if I'm moved to a different space, I'm going to feel comfortable extending this conversation until I'm comfortable with the information that's being presented to me.
Yes.
Okay. Also, just to kind of get into this terminology, because we hear this systolic and diastolic, and just wanted to break that down just a little bit more. And so, which number refers to when the heart beats, and which number refers to in between heartbeats?
Excellent. That's a great question. The top number, which is the systolic number, represents the pressure in your blood vessels when your heart is pumping.
Okay.
The bottom number, the diastolic number, represents the pressure in those blood vessels when your heart is at rest.
Okay.
So that top number, a normal blood pressure is 120/80.
Okay.
We diagnose you with high blood pressure when the top number is above 140 and the bottom number, which is the diastolic, is above 90.
Mm, okay. Okay. Thank you for stopping and giving that reminder and just making that clear, because again, just as the numbers are thrown at us quickly,
Yes.
it's sometimes hard to catch. Okay, am I doing okay right now, or is it that situation that you're talking about? I'm rushing in here because I knew I was late, and was when I presented and said, "Hey, I'm here for this appointment at this time," and then I don't have time to wait. They're like, okay, they call my name immediately. I haven't even fully sat down in the waiting
Mhm.
room and they're calling me in. And back to, again, the earlier part of the conversation, is there that space to allow me to breathe and get settled before taking this number reading?
Absolutely. And I think if nothing else, it's important that patients know those numbers, because often when their blood pressure is taken, a patient's told, okay, your blood pressure is high or your blood pressure is okay. It's all right to ask, what are my numbers? What is my blood pressure?
Mm,
And if you know that the top number should be lower than 140 and the bottom number should be lower than 90, that's powerful information. And you can ask the doctor, well, my bottom number seems to be a little high. Is there something that we should do about it?
okay. Okay. Also, you mentioned the availability of equipment at home in this conversation, and it just made me think as well. I remember I used to see blood pressure like stations at the Walgreens or CVS. Are those still things that can be taken at the pharmacies at like Walgreens or CVS?
Some pharmacies still have blood pressure stations,
Okay.
but the pharmacies also sell blood pressure meters. So if a patient can actually afford it, you can purchase your own blood pressure meter and check your blood pressure at home.
Right. And that's why I was just mentioning a little bit, if they still have those stations at the pharmacy, just
Mhm.
kind of giving that extra option if that's not a piece of equipment that, well, one person can buy for themselves and have at home.
Okay. And some insurances will actually pay for a blood pressure meter. And there are some healthcare systems that will provide you with a blood pressure meter. I know at one point, Access Community Health Center was actually giving away blood pressure meters to patients that were diagnosed with high blood pressure so they could check their blood pressure at home.
Thank you so much for letting us know about that too.
Okay. Okay, now I want to talk a little bit about the underrepresentation of African Americans in clinical trials that actually leads to a lack of data for application of providing the appropriate care. And what you'll see on this slide, I want you to pay attention to this last column because it lists the number of participants who were Black. And the first study had 15%. And you may say, oh, that's low, but that's actually really good when you look at some of the other studies. Like here you have 7%, 5%. These are low numbers. But the African American heart failure trial, this was a study that was conducted that focused primarily on looking at the management of blood pressure in African Americans. And these people were actually diagnosed with heart failure. And it was a group of African American cardiologists that were very concerned about their patients and how their patients were being treated for heart failure. So they actually studied a combination of two drugs, isodil and hydralazine. And what they found was when they gave this combination to African Americans, there was a reduction in heart failure hospitalization and a reduction in all-cause death in African Americans that received this combination. And it's concerning because many African Americans were not receiving isodil hydralazine. So this was a very important study because it showed that this drug combination actually reduced the symptoms associated with heart failure and actually prolonged life. And it was a group of African American cardiologists that actually conducted this study. So,
Wow.
yeah, and I think it was because these cardiologists understood the community and there was a sense of trust, they were able to recruit African Americans in this study. But going forward, I think it's really important for us to enroll in some of these studies because it's very important to get information on how these drugs work in us.
Yes, yes. And the thing that's jumping out at me right now is what you're saying about who is asking the questions or who is getting these research studies started. And so just the importance of continuing to encourage our youth to try their hand at becoming doctors, try their hands at becoming pharmacists, so they can understand and ask questions that are pertaining to us, for us, and by us. And that is just a wonderful example that I'm glad that you included. And also wanting to just bring attention to, again, when you're talking about these single digit percentages and why that's a problem, it's because we represent more than single digits across the country. We,
Right.
as a population, just as a reminder, in the United States, make up about 13% of the population. And so when we're seeing numbers lower than that in these studies, that means that we're not being at least represented on a national scale by how we are made up across the country. And so we want to see at least higher than that 13% in these research studies to know that at least there was an effort made to at least have a representation that's equivalent or higher than our national population for the country. Am I getting that kind of right?
Yes, absolutely.
Okay.
Yes, absolutely. That's
Okay.
very important.
Yes, thank you, thank you, thank you for bringing that up, because I know also we get into these conversations and about our historical legacy and the mistrust and distrust that's there, but there's still a push and a need because as the technology is moving forward, as science is advancing, as we're understanding more about the human body in and of itself, but just more about us as a people and how we live our lives, it is so important that we, if we can, if we are proposed with it, to really go through and understand that the research is being done to be a benefit to later generations. And if we're not participating now, that later generations won't have the benefit. And just again, we are here because people have made sacrifices before us to get us to this point. And so it is within us to continue to think about those that are coming later and being able to do this work now so that they can benefit.
Those are very good points. And Dr. Spears has just joined us.
Oh, okay. Welcome, Dr. Spears, for joining us. I think that you're still muted.
I was being polite. I'm happy to be here. Thank you for
Thank you so
asking.
much. So I just want to give a quick introduction since he's with us now. Dr. Spears is an internal medicine specialist. Is that correct?
That's my specialty, yes.
And I did a little bit of research, and so I believe that it said that you received your uh, training at the Southern Illinois University
School of Medicine, that's
School of
correct.
Medicine. Yes, awesome. And so you've also been practicing medicine for how long?
Close to 30 years.
Close to 30 years. Yeah, I didn't want to flub that number up in what I was able to just extract from the internet, but we're so grateful that you were able to just hop in here and join us. We've been having a great run through of information around hypertension, just the causal factors and things of that sort, the outcomes that we're seeing that are different among the Black population, and just really getting a great run through from Dr. Eva Vivian on this. And the reason that I wanted to have you here with us in this conversation is just to kind of get a sense of what have you seen in your years of practice when people are presenting with hypertension? What are the things that you are suggesting, and how is it that you're walking through with them so that people can get control of their high blood pressure?
Well, I think just like with anyone, most people who come to the office for routine visits and find out that they have high blood pressure, didn't know they had it. And then you get into conversations with them about causes and treatments and things of that nature, you find out that it was prevalent in their families. You'll see other disease states with it. And, people are surprised for the most part by a diagnosis of hypertension because they don't have symptoms for the most part. And so they're resistant to pharmacological treatment at some point, unless you are really specific about the potential side effects of high blood pressure. And then most people will get a little afraid, but you also, from my perspective, you offer them a non-pharmacological way to help control their blood pressures, which would be eating healthy, more vegetables in their diet, for example, reducing the extra salt in their diets we get from our snack foods. And we don't like the way someone cooks something, so we sprinkle a little salt on it, right? And so we need to get them to get out of that habit. But then you just have some people who, when you're looking at them from a clinical perspective, you have to also look to see whether or not differentiate what type of high blood pressure they have, right? So there's essential hypertension and there's secondary causes of hypertension. So depending on the level of their hypertension, it should raise a red flag in my mind as a clinician, whether I should do extra tests. Now, typically, if I see someone who comes in for a regular physical examination and I've gathered all my information and I see they got the strong family history, and I'm going to go, okay, well, we need to do these things because your blood pressure is here, right? And I'm thinking that you may need to be treated with medications to help control your blood pressure. But we're going to do these things first. I'm going to have you monitor your blood pressures at home. I encourage them to buy a blood pressure monitor and make sure they get the correct size. I show them how to use it and when they should be checking and how often they should check, and to either bring back those numbers to me or send them to me through an email or a fax document so I can review them. And I can say, hey, after 2 weeks, of doing nothing but dietary stuff, your blood pressures are really probably not going to change very fast. We need to do something about it. And in that time, I would have had opportunities to review any blood tests that I have ordered on this individual and let them know that I don't suspect they have a secondary cause, but they have essential hypertension. And we need to do certain things for them and get their blood pressures down. I also try to explain to people that having high blood pressure and not treating it has consequences. So you have to talk about those complications of high blood pressure to them so that they clearly understand that if they don't treat it, these things can happen. And, those things could be in the process right now because you may have had high blood pressure for unknown amount of time. depending on how often they go to the doctor. So I see people who don't go for 5, 10 years or haven't gone for 30 years, things of that nature. And so they may be on the verge of having some issues with their heart or their kidneys. And you have to be able to correct that quickly. Otherwise, they're going to, end days are going to be in and out of hospitals and seeing specialists.
So yeah, that's right in alignment with everything that we've been talking about so far. And it really just definitely illuminated some of those things about, you talk just very basically, like if we don't like somebody's cooking, we'll throw a little salt on it. And that is very true to form, just in terms of like any little thing that may happen on a daily basis, and in terms of how we're adding to the situation of potentially having high blood pressure. And so I thank you so much for just going right into it. You were affirming a lot of the things that we were saying on a larger scale. So in practice, you just really laid it out for us. Can we do something about this without adding medicine first?
Well,
And okay,
yeah,
go ahead.
we always try. I think sometimes it's always individually based, right?
Yes.
I can tell you this. I have someone who has a mild high blood pressure. I try to give them an opportunity to not be on medications. But if I have someone whose blood pressure is in stage 2 or 3 high blood pressure, they're on medications right all the way. If they're diabetic, they're going to be on antihypertensive medication. If I suspect that based on symptoms that they may have, that they have underlying heart disease, they're going to be on medications until I can make sure that they don't have something that's going to take their life away sooner than it should be. So you have to take those things into consideration. There's no absolute roadmap to say this is what you do at this point. I don't believe in protocols personally, up to a certain degree. I think you have to look at those things that are recommended by cardiologists and kidney specialists all across the country when you're looking at managing someone's high blood pressure. But everybody doesn't fit that criteria, and so you have to be ready to make changes and be aggressive with some people's in their management.
Okay, yes. And so because we are coming together under the celebration of the upcoming holiday Juneteenth, we want to talk about us as Black folks and what this means in terms of the lifestyle choices that we're making. And so just in terms of those recommendations, just generally around eating habits, what are some things that you're like seeing as far as dietary things that people can look out for? I know you said, just adding salt and stuff like that, we need to watch out. So like staying away from, chips as that main snack thing. We got to add some, celery and carrot sticks and things like that. Yeah. What kinds of things are you talking to patients about in that way?
Well, let me say this, I'm not a nutritionist, but I do know what nutrition looks like, good food looks like, healthy food looks like. And it's hard because it's more expensive than eating bad. Right? You look at our community, and you can't go around the corner without finding McDonald's or Burger King or Wendy's, White Castle, which is horrible. Tastes good though, but it's just horrible for us. But it's fast, it's convenient, and it tastes good, and it meets that need that we have for carbs and salt. And that's just a human need, right? Okay. So you have to a person has to be ready to spend a few extra dollars to go to the local grocery store, get some fresh fruit, fresh vegetables, and cook it right. You don't cook all the life out of it, and you don't boil the life out of your green beans where they're soft and take it now pale instead of a darker green. So I think that those are things that people need to take into account. And it's one of the things that I also try to do with some of my patients is have them see a nutritionist. Say, hey, this is what I have, and then go. I could give them the start. Right, but the nutritionists are going to be much better at telling them how they should eat, how often they should eat it, and how much. Right, and you have to take in those other variables like diabetes and their weight and things of that nature when you're making these decisions for them to eat healthy. And it's hard to maintain that because again, it's costly, right? To eat healthy, it just is. But it's more costly to wind up in the hospital from because you had a stroke or a heart attack because you weren't taking care of your health.
Okay, I just want to put an extra emphasis on that. Okay, what cost are we trying to pay? Are we trying to pay an upfront cost? Are we trying to pay a later down the road or hospital stay cost? Now, I've heard this, and I think that this fits here. Is an ounce of prevention is worth a pound of cure.
That's right.
Is that what we're pointing to right now?
But you know what, people, we look at that, and you know, I won't say we're all guilty of that, but you have to take that into account because a lot of people don't even have the money to buy medications. So what do you do, right? You can encourage them and say, hey, look, I need you to get these 5 servings of fruits and vegetables every day, right? Cut back on these things and you could save some money. And then now if you need medications, we try to find medications that are inexpensive, right? And for the general population, and try to keep you from having to need the more expensive medications for your health.
Yeah,
I'd also like to chime in to say though that sometimes we have to help patients find places to purchase healthy fruits and vegetables. There are some food pantries that actually give away fruits and vegetables. Grocery stores will actually donate fruits and vegetables maybe a day or two before they perish. So it's a matter of trying to find where those resources are, because there are some people that actually can't afford it. And McDonald's is a cheaper option. With the dollar meals, they can feed each child for $1 each. And it's tough for some people.
Right, that's right. As an example, I mean, in the area I live in Illinois, there's a town that we spend, my fraternity spends a lot of time doing social service stuff in. It's called North Chicago. And they had no major grocery stores. They had to go to Waukegan to get their groceries. I mean, you find these little small stores, 7-Eleven type stuff that will have food on the shelf and things like that. And this is where they would have to shop. And they just finally got I think it's a Whole Foods there. And so, if we don't demand these things, right, in our neighborhoods, this is what we get, right? And you're absolutely right. There's some food pantries that do fresh vegetables and things like that. But that's you got to keep going back and forth. And there is, and the grocery stores do donate food. And most of us think because they can ready to throw it out that it's bad, and it's actually not. The shelf life is much longer than what we think. When you buy stuff, just because it turns a little brown doesn't mean you can't eat it.
Okay. Yeah, thank you for putting that out there, because I know I got some spotty bananas at home, and I got to go ahead and figure out how to incorporate those and eat them, rather than think that, oh no, they got some spots on them, they're not no good. But also I just wanted to, we gotta talk about some of these risk factors as well that are not just food related, or I mean just in terms of like healthy food and options and stuff like that, because I'm looking at a list of things, and so smoking and alcohol are those kinds of things that are part of these things that as adults they're an option for us to provide a little bit of stress relief here and there, but just the reasons that we're talking about, it's needed to hear and say once again, just anytime we can, that those things are going to be bad in terms of this conversation around hypertension and blood pressure, high blood pressure. Can you say a little bit of something about that, Dr. Vivian or Dr. Spears?
Well, I'll let Dr. Spears go first.
Well, yeah, I think that people should know by now that tobacco smoking or chewing or vaping is not good for you, right? And it adds to the risk for further cardiovascular disease. It's probably tobacco is the worst thing you could do to your body and keep you unhealthy. We see more death as a result of coronary artery disease and lung cancer and COPD with people who smoke. And if you smoke and you have high cholesterol and you have high blood pressure, your diabetes, you increase your risk of well, there's a thing we do, it's called the 10-year risk assessment for heart disease, right? It's like a little calculated value that you can do with patients, and based on their race and their blood pressure, whether they smoke or have diabetes, things of that nature, what their cholesterol is like. And so tobacco increases your risk, greater than diabetes does. And so, if you're smoking and you want to be healthy, you can't smoke and be healthy at the same time, even if you feel okay, right? Because the consequences down the road are tremendous, right? And, just using fit my family, my brother, who passed away a few years ago from gastric cancer, was a big smoker, big drinker, right? And he goes, you need to quit smoking. Well, I got to die from something. I'm going like, well, that don't make no sense, right? And we got to, get into a big argument about that. And, I'm kind of aggressive when people say stupid stuff like that. And so I pointed out to him that your mother died from lung cancer and she was a smoker. Is that what you want, right? Do you really, really want to cut your life short because you got to die from something? Well, I'd rather die from getting hit by a train than die from lung cancer and can't breathe in my last breath, right? Because I smoked myself to death. That don't make any sense to me. So, yeah, we got numerous risk factors that will affect your ability to control your blood pressure. If you're a drink alcohol, you should reduce the amount that you consume, because that in itself will increase your risk. If you're a diabetic, you need to control your blood sugars the best way you can. Diet and exercise, it all comes back to diet and exercise, right? Always does. And so those are the things you have to do as far as I'm concerned. And I try to stress that with my patients, friends, frat brothers, everybody. Right? You don't come to me and say, hey man, I got this. And I go, well, stop doing that, right? You can't smoke and tell me you want to be healthy. You just can't.
I don't want to shy away from it. So I really appreciate that, and making it very personal. I do see that we got a hand raised here from the audience participation. If you unmute yourself, we can hear from you. Yeah.
Hi, I'm Polly. I'm a community-based public health nurse. So thank you, Dr. Vivian and Dr. Spears, for being here. It's been a very informative and educational presentation, Dr. Vivian, to listen to you. I'm really here just to listen and become educated about, the health disparities that are currently here in our Madison and Dane County community. But I also I just had a few questions that came to mind as I was listening to your presentation, Dr. Vivian. So prior to coming to public health, I worked as a home care nurse and then also a geriatric clinic nurse. So I have a lot of background in, the blood pressure monitoring, the education, blood pressure management of a healthcare team. And what I realized when I was listening to your presentation was we learned a lot about general hypertension, right, in the general community. And there's not a lot of focus or emphasis on the disparities that are present within like the Black community. And so how do we ensure that there's consistent education among nursing staff, medical students, pharmacy students on the disparities that are real and important and are affecting our communities? How are we ensuring that that's within the education that's being provided, at the university? And then also even like in our professional work, all these efforts on diversity, equity, inclusion, how do we ensure that these large healthcare systems are ensuring that their staff are consistently getting education, training that can inform them and really encourage them to provide care that is equitable?
That is a very good question. Thank you for bringing that up. I think that the recent pandemic clearly showed the disparities that we face in our country, and also showed that we as a profession, all healthcare professionals, need to be the trusted messenger. And I think what was very disappointing was the numbers of African Americans that did not become vaccinated because they didn't feel comfortable going to their healthcare provider seeking accurate information. And in my opinion, that was something that we should have been working on. I think it's very important that all of the health sciences involve their students in rotations and activities in communities of color, particularly low-income, under-resourced communities. In Madison in particular, Dane County is a wealthy county. It's one of the wealthiest counties in the country. And unfortunately, we have many that think that everyone has the same access to care and to services as the affluent, and we know that that's not the case. Often education is lacking as well. So as a healthcare professional, it's really important to build that relationship with that patient so that when the patient is faced with all this information, which is available on the internet, through friends, they come back to, for example, Dr. Spears and say, well, you know, I heard this about blood pressure, but is that true? Because how many people are walking around with elevated blood pressure and they don't have any symptoms? That's why high blood pressure was nicknamed the silent killer. They feel fine. Or maybe someone told them, oh, you have high blood pressure, you should be on medication. And then someone else told them, look, you don't need to take a medication because you're not feeling bad. Wait until you get a headache or some other discomfort before you take a blood pressure medication. They need someone within the healthcare profession that they trust, that they can go to, that can give them accurate advice and accurate information. And unfortunately, I would say that I think all the health sciences schools at UW can work on improving that. When we talk about diversity, equity, and inclusion, that's including everyone. So healthcare is a major issue, and all the students should graduate and be comfortable working in underserved communities. And they should be familiar with the challenges that people within these communities face when attempting to lead a healthy lifestyle. We could go on and on about this, but I want to give others a chance to respond to this question.
I think you're absolutely spot on. I think that there's a mistrust from people within our communities about going to the doctor. I've seen it, I witnessed it. I do talks within the community that surround me, Waukegan, North Chicago, Zion. And the general census that I have is that, you know, people will come and they will listen, but I don't think that they trust, right? And we can say, oh, you know, they don't want to travel to go see someone. You know, we want to see people who look like me, you know, from out of those communities, but yet they don't want to go where I am, right? They'll come sometimes to these talks and things like that. And you know, you hope that you get through to someone when it comes to that. And that's what you do. I mean, we have, I think, as a profession, have a responsibility to make sure that we are spending a few moments of our lives talking to people about their health, common topics. So I try to do my part. I know you know, for example, I take public aid in my office, and you know, I'll see whoever comes through my door, and I will tell them what I know. Hopefully they'll take it back to their friends and family. But what they do when they come is they tell me what they said. And I go, well, who's they? Who told you that, right? And he go, well, they said this and they said that. I said, okay, you know, let's stop talking to they. You need a doctor or a nurse practitioner or a PA, somebody who's been trained to talk to you about what they're saying so that you can have the right story. There's so much misinformation out there, and everyone's trying to utilize your fears and anxieties about your health by selling you something that you don't need, right? And so I tell my patients all the time, and they say, well, they said I could take this. I said, where are you getting it from? Say, Jewel. I said, where is it at? It's in the pharmacy section. I said, no, pharmacy is behind the counter. So you're looking at something that's over the counter, right? And I said, did you ever turn it and look at what the ingredients are? No, it just says it's good for this. I go, okay. This is what I want you to do. I want you to go back there, pick up that bottle and go find something else that says it's for something else. And I want you to turn around and look at the ingredients. They're all vitamins, right? I said, if it was all you needed to do was take vitamins to fix your liver or your kidneys or your blood pressure, I wouldn't have a job, right? It's not that easy to manage your health. You're taking over the counter stuff and it's costly, just like your medications might be, right? But it's more costly to you in the long run because you're not treating yourself appropriately. So I think there's always this education drop off with people. And we kind of have to keep doing what we can do to reach them and have them understand that, you need to talk to a doctor or somebody who's trained in this on a regular basis to help you understand what's going on. Otherwise, you'll be, in somebody's hospital bed with your first stroke or your first heart attack before your 50s and 60s. This is what we see in our communities, right? So education is key. I can tell you that with the organizations that I belong to, we're doing everything we can to educate men in particular about their health. And part of the things that we should be doing also is reaching out to the general public, right? And let them know we're having these talks. So we got Zoom now. You don't have to come into a building to listen to somebody or several people who are professionals, and this is what they do, and they're offering you this advice for free. And that's what's key. Right now, what you do with that information is after the fact is important too. But we want you to take what you learned and utilize it and put it into practice so that I don't have to go out to work every day, right? And you don't have to see me be sarcastic when you come into my office about the stuff that you're doing. And I can be very sarcastic in a funny way, but
Yes. Did you feel like those insights? There was lots in there
Yes.
in both answers. Did you catch some of those things? So I just wanted to highlight the 2 points around relationships and trust in terms of,
Definitely.
yeah,
Yeah, I feel like all of that is so interconnected, right?
yes,
Because
yes,
with the education, you need your healthcare providers to be informed, educated about just not people in general, but your history, the higher risk that you have because you're a Black person, the socioeconomic status considerations, all those social determinants of health. So like at the public health level, I'm kind of thinking of that's kind of where primary prevention comes in, right? If we can help improve social determinants, we can at least help to lower that risk factor of developing hypertension. If we can train our professionals to be culturally competent so that they're providing care that is culturally sensitive, informed, intentional for these groups of people, then it'd be more impactful compared to, providing care for a non-Black person or someone of a different ethnicity. So those are very great responses. Thank you so much for all the insight.
And I'd just like to mention one thing. We often forget that African Americans have been mistreated within the healthcare system.
Yeah.
There is some historical trauma.
Mhm.
I mean, there are those that remember Tuskegee, but even beyond Tuskegee, many Blacks have had very bad experiences when working with healthcare providers. And sometimes that unconscious bias tends to emerge, and people as a result just feel hesitant about going back to see a healthcare provider because they don't want to deal with that type of experience. So I think it's important that you keep in the back of your mind that this patient sitting in front of you may have had some negative experiences in the past with the healthcare system. So that building that trust, sometimes you've got to, build the bridge again.
Definitely. It's a very great point. Thank you.
So as we're coming into the last few minutes of this particular time, I wanted to just do some continuum work in terms of let's have a couple points about what should we be gearing towards our youth from this conversation about hypertension and high blood pressure? What are those strategies that they need? I know we talked about it, but let's focus and say, youth, this is what we need to understand about hypertension. And then we can address the aging and elder populations as well.
Well, from my perspective, if I deal with adults for the most part. Okay. So
Okay.
I'm seeing people 18 and up. But if there's an opportunity to talk to high schoolers about health issues, I tell them the same thing I would tell their parents, right, about their health. I said, listen, what I need you to do is look at your parents. You should know what their health history is. So because what they get, you might get. And so if you can see that they are have diabetes, or they have high blood pressure, or they've had a heart attack or a stroke, your job is now to say, I don't want that to happen to me when I get to this point in my life. So I'm going to make some changes now in how I do things, right? But young people don't always catch that right away, because the common saying is that they feel they're immortal, right? And that's not going to happen to me. Look at me, I'm fit and I can run up and down 20 flights of stairs and I don't even get winded. Well, it's the accumulation of things that cause you to have these other issues down the road. So if you can do that now, you want to do that when you're 40 or 50. You don't start smoking. You don't do drugs. You don't drink a lot of alcohol. Those things you try to avoid. And you don't fall into the pitfalls of, well, if I don't smoke cigarettes, I can vape, right? No, you can't, because there are dangers in that also. And so that's what you do. I think you take it down to their level of interest and say, look, this is what you don't want. This is how you try to avoid those things. Now it's up to you, right? But talk to your parents. They should know their parents' history, their grandparents' history, uncles and aunts' history, so they can avoid those traps that the rest of them have already fallen into.
My research is actually focused on diabetes prevention. And 10 years ago, I focused on the youth. But it was interesting. They told me that while their peers influenced them, that their parents or the caregiver had the greatest influence over their health. Mm-hmm. So now I'm focusing on working with grandmothers who are caregivers, so that they can serve as role models for their grandchildren. And we hope that the grandchildren model those behaviors. So I really feel that while we can impart a lot of information to youth, it's really important that we focus on the parents or the caregivers so that they model these behaviors for the youth. Because for a lot of young people, particularly between the ages of 5 to their teens, they come home and the parents are the ones that purchase the food. So if the parents are eating potato chips and other junk, guess what? They're going to eat the same thing. But if the parent is being physically active and watching what they eat, then their child will model those behaviors. So I think it's more of a family affair.
Yes, yes. Yeah, totally. And so I appreciate those perspectives, and really just the strength of doing the things that are claimed to be simple, but being able to do them over a long period of time. And so, however that youth have access to fresh fruits and vegetables, and being able to understand that food pyramid, right? And what it means to incorporate into their life, those basics, along with that choice of activity, right? So what is it that you like doing, and doing that for a long time, or finding a way to be able to do that? I know that I played football, full pad contact football in high school, and I had to let that go. let that dream go. We understand that, even professionals' careers taper off, wane off, and come to a close. And so what are those activities that are going to be sustainable, and finding a liking for maybe trying something new. I ended up being exposed to a game called Frisbee golf. And it just, being able to have a couple Frisbees that you're taking to the park and being able to take a walk through the park while throwing these Frisbees. And so that was something that transitioned for me and was just an interesting kind of way to be able to say, hey, I'm going to go do this when I have some downtime, to be able to get outside, be able to find an activity. And so whatever it is, I know that in the schools and gym class, you have these rotations of activities that you do, and everything from square dancing to hopscotch, to all these, the badminton, to all these different kinds of things. And so that's what I was hoping to just highlight as well for the youth, and not just thinking that those things are not going to serve you well, just being able to pick up on those basics. But I really appreciate that connection that you made to it being a family affair, and that we do what we see. And so just being able to encourage the adults that the kids are watching. And so, how are we able to be good role models in our adult habits, to be able to make sure that those that are coming up behind us understand that this is going to do well for them. I know that it might not be within our families, but we see Uncle John or Uncle Tim or Uncle Fred that's still going, right, and still being able to do. I know that those figures are out there. So being able to look into saying, hey, what are some things that are sustaining you, or can kind of pick up on those things, and being able to incorporate those things into your life, are things that are going to serve you well. So just a couple parting words of advice from each of you. Let's start with Dr. Spears.
What I would tell folks, and you're worried about your health, first step is to talk to a doctor. Find somebody that you like, and stay with them, and have those discussions, and then find out where you stand. You may be healthier than you think, and you may not be. So I think the first thing is to establish yourself with a primary care physician, whether it's family practice physician or an internal medicine doctor like myself. That's where you start at. You don't start with the cardiologist. Okay. You don't.
Awesome.
Okay.
Awesome.
You start with your family practitioner or your internist.
Nice. Dr. Vivian.
I echo Dr. Spears' comments, and just encourage everyone to be physically active and to eat as healthy as possible, because whether it's high blood pressure, diabetes, or other chronic diseases, we found that lifestyle change really makes the difference.
Wow. Well, folks, we are so grateful for you for paying attention and tuning in with us. And we want you to just know that you're not alone in whatever it is that you're going through, and that we do have the answers. We just have to take the chance to go out and find the good people that are willing to have the conversation with us, so that we can apply these things. And so this is going to wrap up this year's session for the Hypertension and Black Wellness conversation that is hosted by Kuji Chagulia's Madison Center for Self-Determination in this year's celebration of Juneteenth. We wish you all well, and we welcome you to continue this conversation in your own lives. Thank you so much for joining us, and have a wonderful day. Right.
That was excellent. You did an excellent job. Don't you feel wonderful?
I do.
That turned out great. I really thought that turned out great.
Yes. Thank you so much. Juan, will you be able to, excuse me, Juan, Josue, will you be able to do some editing? I know you're still recording here.
Okay, I'm going to get off. Take
Okay.
care.
Okay. Thank you so much. All right, gonna hop off here. It is now noon. We definitely did well with those 90 minutes. And Juan, thank you. I'm gonna kick myself, continue to kick myself. Josue, and I should know it's Josue, translated Joshua. And so Josue, thank you so much for your help in working this. And I'm just going to take a quick break here, and I will join you for the next session about 15, 20 minutes. Thank you so much.